Hi guys, welcome back to Prague ICU. I'm Mikal Pazdernik, and in this presentation we'll provide you the most updated information about nutrition in ICU. Critical illness is accompanied by a hypermetabolic state related to the activation of various catabolic hormones. The situation results in elevated energy expenditure, thus increasing the risk of malnutrition. Accurate determination of the patient's energy requirements is of great importance, as nutrition support, including optimal energy supply, is a key component for a positive clinical outcome. Underfeeding has been shown to result in an increased hospital length of stay, increased incidence of complications such as infections and organ failure, and increased risk of mortality. In contrast, overfeeding has also been associated with various complications, including hyperglycemia, hypertriglyceridemia, hepatic steatosis, azotemia, hypercapnia, and increased rate of mortality. Let's go through the nutrition in ICU overview. Both ESPEN and ASPEN guidelines are analyzed and cited. One of the most important questions is when to start feeding. ESPEN recommends within 48 hours, whereas ASPEN between 24 and 48 hours. What is the choice of route? Enteral nutrition is always preferred, whereas jejunal administration should be used in high-risk aspiration and gastric paresis. How should we calculate the energy supply? If we can't use the indirect calorimetry, then we should estimate the correct energy expenditure. How is it with proteins? There is an overall trend to administer higher doses of proteins. ESPEN recommends 1.3 to 1.5 grams per kilogram per day. In contrast, ASPEN guidelines recommend up to 2 grams per kilogram per day. There is no strict dose of carbohydrates that needs to be administered, but ESPEN guidelines recommend max dose of 5 milligrams per kilogram per minute. Lower doses are desirable for critically ill patients, diabetics, septic patients, or patients on steroid therapy. Finally, average lipid dose should be from 0.7 to 1.5 grams per kilogram per day, and we should take into account another sources of lipids, such as propofol. Back to energy expenditure assessment and quantification. In critically ill mechanically ventilated patients, energy expenditure should be determined by using indirect calorimetry. If calorimetry is not available, using VO2 from pulmonary arterial catheter or VCO2 derived from the ventilator will give a better evaluation of energy expenditure than predictive equations. The predictive equations are associated with significant inaccuracy, leading to over or under evaluation of the needs and inducing over or underfeeding. Indirect calorimetry is a gold standard for assessing basal or resting energy expenditure, although unfortunately not currently available in many medical centers. Indirect calorimetry is a technique that measures inspired and expired gas flows, volumes, and concentrations of O2 and CO2. It allows measurement of oxygen consumption and carbon dioxide production. Metabolic card can be simply attached to mechanically ventilated patients or to self-ventilating patients uses calorimetry. Here we can see several equations for predicting the resting energy expenditure. For obese patients, it is recommended to use an ideal body weight based on the patient's height calculated to BMI. Here we can see that patient's ideal body weight, while having 160 centimeters and 110 kilograms, is 52 kilograms. We need to be aware of that. Let's come back to guidelines consensus. Enteral nutrition is the preferred way of feeding in a critically ill patient. What is the rationale? Enteral nutrition is preserving intestinal epithelium, stimulates secretion of brush border enzymes, enhances immune function, preserves epithelial tile cell junctions, and prevents bacterial translocation. Enteral nutrition decreases morbidity and mortality. Always think of administration of all parts of nutrition. The most important substance are proteins, carbohydrates, lipids, and micronutrients. Nutrition dose should always be quantified based on phase of critical illness. Hypocaloric nutrition, not exceeding 70% of estimated or measured energy expenditure, should be administered in the early phase of acute illness. After day 3, caloric delivery can be increased up to 80 to 100% of measured EE, but still up to 70% of estimated EE. If predictive equations are used to estimate the energy need, hypocaloric nutrition, up to 70% of estimated needs, should be preferred over isocaloric nutrition for the first week of ICU stay. When should we apply supplemental parenteral nutrition? According to ESPEN guidelines, in patients who do not tolerate full dose of enteral nutrition during the first week in the ICU, the safety and benefits of initiating parenteral nutrition should be weighed on a case-by-case basis. Parenteral nutrition shouldn't be started until all strategies to maximize enteral nutrition tolerance have been attempted. When the level of energy needs to be provided by enteral nutrition is below 60% 3 days after ICU admission, then we should consider parenteral nutrition. Hence, the optimal time point is between days 4 and 7. When assessing the possibility of parenteral nutrition, according to ESPEN guidelines, all patients should undergo evaluation of their nutritional status within 48 hours of admission. Supplemental parenteral nutrition should only be considered in high-risk patients who continue to receive hypocaloric enteral nutrition, less than 60% of EE, after the first week of hospitalization. Proteins are the most crucial element of nutrition in critical illness. Critical illness is associated with marked proteolysis and muscle loss, that is associated with ICU acquired weakness. A higher protein intake and physical activity might be needed to overcome anabolic resistance associated with older age and critical illness. Again, here we report the recommended doses of proteins per day. As per ESPEN guidelines, it is recommended to administer 1.3 to 1.5 grams per kilogram per day. In contrast, according to ESPEN guidelines, which recommend the dose of 1.2 up to 2 grams per kilogram per day. But we need to be aware of disadvantages that are associated with excessive protein intake, which is azotemia, hypertonic dehydration, hyperammonemia, and metabolic acidosis. What about lipids? Omega-3 and omega-6 polyunsaturated acids are essential parts of lipid emulsions. High levels of omega-6 fatty acids are associated with inflammatory potential, whereas omega-3 acids possess anti-inflammatory properties. ESPEN guidelines recommend that lipids should be an essential part of parenteral nutrition for energy and to ensure essential fatty acids provision, and that intravenous lipid emulsions can be administered safely at a rate of 0.7 grams per kilogram up to 1.5 grams per kilogram over 24 hours. Excess fat can lead to respiratory syndrome distress, coagulopathy, elevation of liver enzymes, immunosuppression, overload of the reticular endothelial system, hypertriglyceridemia, and hypercholesterolemia. The risk of hypertriglyceridemia with parenteral nutrition increases in patients with renal failure, corticosteroid therapy, sepsis, acute pancreatitis, and elevated glucose levels in the blood. Carbohydrates are preferential substrate for production of energy, but in critical illness, insulin resistance and hyperglycemia are common secondary to stress. Carbohydrates should be theoretically eliminated from the diet, but it is probably safer to give around 150 to 350 grams per day. This may be explained by organ preference on glucose. But we need to be aware that excessive glucose-based energy provision is associated with hyperglycemia, enhanced CO2 production, enhanced lipogenesis, increased insulin requirements, and no advantage in protein sparing in comparison with a lipid-based energy provision. Micronutrients are essential for the metabolism of carbohydrates, proteins, and lipids, for immunity, and antioxidant defense, for endocrine function, and for DNA synthesis, gene repair, and cell signaling. Ready-made parental nutrition products are free of vitamins and trace elements. To enable substrate metabolism, micronutrients should be provided daily with parenteral nutrition. Here we provide nutrition recommendation in specific illness patients. Please focus especially on severe undernourished patients or in patients with sepsis. Further on, take a focus on specific illness patients such as renal failure patients, such as patients on renal replacement therapy, on obese patients. In non-intubated patients not reaching the energy target with an oral diet, oral nutrition supplements should be considered first and then enteral nutrition. In non-intubated patients with dysphagia, texture-adapted food can be considered. If swallowing is proven unsafe, enteral nutrition should be administered. Here are several supplementing formulas for non-intubated patients. All products can be mixed in water, but due to neutral taste, it is rather recommended to add them to drinks, milk, yogurts, porridges, or common foods. We can mention products such as Phantomalt powder, which is a source of maltodextrin, Protifar, protein supplementation, or Fresubin powder, again protein supplementation. Sipping represents the complete source of nutrition. It is usually available in 200 ml bottles. Standard 1 kilocalorie per milliliter. It contains 1/3 of daily dose of vitamins and trace elements, and 1/6 of the daily dose of energy expenditure, usually low content of minerals, but can be also high caloric, up to 2 kilocalories per milliliter. Here are the most commonly used products for sipping. Enteral Plus, Nutridrink, Fresubin Juicy. They are usually served 2 up to 3 times a day as a supplementary nutrition. We can mention also the product suitable for hemodialyzed patients, Nepro HP, which is high caloric and have low content of sodium and potassium. Also can be put into NG tube. What is the nutrition approach in intubated patients? Examination of GIT motility, contractility, and peristalsis is possible. Nevertheless, their absence is not an absolute contraindication of enteral nutrition. Gastric access should be used as the standard approach to initiate enteral nutrition. In patients with higher risk of aspiration or intolerance of gastric administration, it is recommended to commence enteral nutrition with jejunal administration. In all other patients, gastric administration is preferred. In patients with high risk of aspiration, continuous administration plus prokinetics, bedheading, and chlorhexidine mouthwash is recommended. Diarrhea is not an indication to halt enteral nutrition. However, it is desirable to clarify the origin of diarrhea and adopt the most suitable therapeutical approach. Glycemia should always be below 10 mmol per liter. Another important issue is the mode of enteral nutrition. Should we give boluses? Should we administer continuously or intermittently? In bolus feeding, syringe or gravity is used to deliver feed over a 5 to 10 minutes period 4 up to 6 times a day. There are several disadvantages. In contrast, continuous feeding is provided via a feeding pump for several hours during a 24-hour period. Usually, in the ICU setting, patients are continuously fed over 20 to 24 hours. It has definitely its advantages and disadvantages. Lastly, we can provide feeding intermittently. So, continuous or bolus feeding. There were reported significant reductions of diarrhea with continuous versus bolus administration, whereas no difference was identified in other outcomes, including mortality. Contrary, bolus feeding could provide a greater stimulus for protein synthesis. Limited data suggest that bolus and continuous enteral feeding can achieve the same target without an increase in side effects in any of these routes. Anyway, ESPEN guidelines favors continuous feeding. What about prokinetics? In critically ill patients with gastric feeding intolerance, intravenous erythromycin should be used as a first-line prokinetic therapy. Alternatively, intravenous metoclopramide or a combination with erythromycin can be used. Effectiveness of erythromycin or other prokinetics is decreased to 1/3 after 72 hours and should be discontinued after 3 days. Here is the content of frequently used enteral nutrition formulas such as Gevity and osmolyte Hycal, both containing 1.5 kilocalories per milliliter. Again, Nepro containing 1.8 kilocalories per milliliter for renal failure patients. Enteral nutrition should be delayed if shock is uncontrolled and hemodynamic and tissue perfusion goals are not reached. In case of uncontrolled life-threatening hypoxemia, hypercapnia, or acidosis. In patients suffering from active upper GI bleeding, in patients with overt bowel ischemia, in patients with abdominal compartment syndrome, or if gastric aspirates are above 500 milliliters over last 6 hours. Early enteral nutrition should be performed in patients receiving ECMO, patients with stroke, in patients with severe acute pancreatitis, in patients after GI surgery, in patients after abdominal aortic surgery, in patients receiving neuromuscular blocking agents, in patients managed in prone position, and regardless of the presence of bowel sounds, unless bowel ischemia or obstruction is suspected in patients with diarrhea. As mentioned before, according to ESPEN guidelines, parenteral nutrition should be commenced between days 4 to 7 in case of inadequate enteral nutrition. As per ESPEN guidelines, only in high-risk patients after day 7. In following slides, we provide the most frequently used commercial parenteral nutrition bags. NutriFlex Plus contains 2 liters of nutrition in 2 chambers. Total energy is 1580 kilocalories and comprises 96 grams of proteins and 330 grams of carbohydrates. There is more proteins and more carbohydrates in NutriFlex Special, 105 grams of proteins and 360 grams of carbohydrates. In NutriFlex Lipid Plus, there is less amount of proteins and carbohydrates, but lipids are part of the solution. Smofcabivan is a high-caloric 3-chamber bag containing reasonable amount of proteins, lipids and carbohydrates. Similar to Smofcabivan is Olimel containing slightly more proteins and less carbohydrates. In case we need to administer high amount of proteins, such as in patients on renal replacement therapy, we can add preparates like Nefrotect, which is a source of amino acids. 500 milliliters contain 200 kilocalories and 50 grams of amino acids. In case we use 2-chamber bags, we can use lipid emulsions such as Smoflipid and Lipoplus. They both represent additional source of energy. Therefore, we need to be aware of that. Parenteral micronutrients involve vitamins and trace elements, and they are indispensable part of parenteral nutrition. Finally, we can cope with several syndromes associated with nutrition. Refeeding syndrome is most commonly observed within 2 days after admission and initiation of enteral nutrition. Metabolism switches to free fatty acids, oxygenation to safe protein. After nutrition initiation, metabolism switches back to glucose, and reduction of extracellular concentration of phosphorus, potassium, magnesium, and thiamine is observed. It can lead to potential electrolyte fluctuations involving metabolic, hemodynamic, and neuromuscular problems. Who are patients at risk? Patients with BMI less than 16, patients with nil by mouth or minimal nutrition intake for more than 10 days, patients with weight loss more than 15% in 3 to 6 months, and patients with impaired ionic balance. Refeeding syndrome. What is the prevention of this syndrome? To avoid overfeeding, early full enteral nutrition and parenteral nutrition shall not be used in critically ill patients, but shall be prescribed within 3 to 7 days. We should start feeding at less than 50% of energy requirement, then slowly increase the rate if no signs of refeeding appear. In patients with high risk, commence nutrition with 5 kilocalories per kilogram per day and with cardiac monitoring. Don't forget on vitamin supplementation and on ionic supplementation. Fat overload syndrome is a complication of IV lipid therapy, most commonly observed with formulas on soybean basis. Symptoms are headache, fever, icterus, hepatosplenomegaly, ARDS, or spontaneous hemorrhage. Laboratory symptoms include anemia, leukopenia, thrombocytopenia, fibrinogen depletion, coagulopathy. Prevention is maximum lipid infusion rate at 0.11 grams per kilogram per hour. Lastly, overfeeding syndrome symptoms are azotemia, hypertonic dehydration, or metabolic acidosis. Underlying is hypercapnia, leading to hyperventilation and respiratory insufficiency. Thank you very much for listening and stay tuned for more interesting stuff from Prague ICU.